Good morning. So we are Group 2 and we are here to present Case 20. Next slide. So we have patient EA, who is a 59-year-old male, right-handed, Filipino, married, Roman Catholic from Cavite. He is an employee in an engineering company and was a college graduate. He came in with a chief complaint of bilateral lower extremity weakness of 2 weeks duration. Next slide. So 1 month prior to admission, the patient complained of intermittent chest pain, described as heaviness, no difficulty breathing, no shortness of breath, no easy fatigability was noted. The patient sought consult and was diagnosed to have acute coronary syndrome. He was advised to undergo coronary angiogram and percutaneous coronary intervention. During admission, he was diagnosed with pneumonia and two COVID-RT PCR tests were negative. The patient was discharged well until 13 days prior to admission. The patient complained of progressive weakness, described as easy fatigability and difficulty ambulating and slurring of speech. He described his difficulty in ambulation, such as difficulty standing up from sitting position, climbing up the stairs, and easy fatigability on walking after a few steps. He also complained of episodes of difficulty in straightening his neck after neck flexion. In the ensuing days, other symptoms include progressive dysphagia, dysarthria, as well as loss of appetite. He was mostly bedbound since then and ambulated with assistance but had occasional exertional dyspnea on ambulation. No complaints of headache, blurring of vision, dizziness, or vomiting. Persistence of symptoms prompted ER consult and subsequent admission. Next slide. So the pertinent data would be for the pertinent positives: progressive weakness, easy fatigability, difficulty ambulating, slurring of speech, dysarthria, dysphagia, difficulty straightening neck after flexion, loss of appetite, exertional dyspnea, as well as his recent diagnosis of acute coronary syndrome. For pertinent negatives, there was no headache, no blurring of vision, no dizziness, and no vomiting.
The review of systems revealed anorexia, which may be related to the patient's systemic illness and muscle weakness. It also revealed occasional exertional dyspnea, which may be related to the patient's heart failure. And it also revealed easy fatigability, which may be related to the patient's muscle weakness and underlying heart failure. The rest of the review of systems was otherwise unremarkable. The past medical history shows the patient's conditions and medications. The patient takes ticagrelor, aspirin, nebivolol, and atorvastatin for coronary artery disease post-percutaneous coronary intervention. Um, and he also takes Entresto, furosemide, and trimetazidine for heart failure with reduced ejection fraction. He also takes sitagliptin and metformin for type 2 diabetes. Among the patient's medications, atorvastatin is the most relevant as statins are known to cause drug-induced myopathy. The other medications, such as furosemide, may cause weakness indirectly through electrolyte disturbances, while beta blockers, like nebivolol, may cause fatigue, but they are less likely to explain um, the progressive muscle weakness of the patient.
So for the family, social, and travel history, the patient has a family history of type 2 diabetes mellitus, specifically his sibling. But he has no history of hypertension, heart disease, autoimmune disease, or cancer. He also denies smoking, drinking alcoholic beverages, and using illicit drugs, and also has no history of travels. Next slide, please.
The patient was awake, alert, and conversant, and not in respiratory distress. Vital signs were within normal limits: blood pressure of 110 over 80, heart rate of 88, respiratory rate of 21, temperature of 36.5, and oxygen saturation on room air. On ENT, sorry, on ENT examination, the patient had anecteric sclerae and pink palpebral conjunctivae with no tonsillar pharyngeal congestion and no cervical lymphadenopathy. The chest and lungs showed equal chest expansion with clear breath sounds and no retractions. On cardiovascular examination, the precordium was adynamic with normal rate and regular rhythm. The point of maximal impulse was located at the fifth intercostal space at the midclavicular line, and no murmurs were appreciated. The abdomen was flabby, soft, and non-tender with normal active bowel sounds. Examination of the extremities revealed full and equal peripheral pulses, capillary refill time of less than 2 seconds, and no cyanosis, indicating adequate peripheral perfusion. Um, the patient has no systemic abnormalities on general physical examination, suggesting that the weakness is more likely due to a neuromuscular cause. Next slide, please.
For the neurological exam, for the mental status examination, it shows intact higher cortical function. This suggests that the cerebral cortex is not involved. Next slide, please. For the cranial nerves 1 to 6, most are normal except for cranial nerve number 2. There's a slight decrease in visual acuity. Next slide, please. For the cranial nerves 5 to 12, they're intact. And however, there's a weak gag reflex in cranial nerve 9 and 10 and dysarthria in cranial number 12, consistent with the HPI, such as yung meron siyang slurring of speech and progressive dysphagia and dysarthria. Next slide, please. For the motor exam, you can see that there's a symmetric weakness between right and left, where lower extremity is weaker than the upper extremity. And within the lower extremity, proximal muscles are weaker than the distal. This is very typical of myopathy with some exemptions like your IBM, which presents distally. And you could also see that there is hypotonia in bilateral lower extremity. This is consistent with the patient's chief complaint and HPI. For the bulk, there's normal bulk, normal bulk. There's no atrophy or pseudo hypertrophy yet, which is kind of expected given the temporal profile of the patient. It's kind of acute to subacute pa, so wala pa. Pero if I'm going to add an additional physical exam for this patient, I would have measured the muscle size, and if I'm expecting a channelopathies, which will be discussed later pa, I would have checked for myotonia. Next slide, please. For sensory examination, it's all normal for all modalities. Next slide, please. For the deep tendon reflexes, they are mostly absent with only diminished tricep reflexes bilaterally. Babinski reflex is absent, consistent with the lower motor neuron defect. The cerebellar examination is normal and the meningeal signs are absent. Next slide, please.
So for localization, we need to rule out lower motor and upper motor neurons. So we rule in PNS or lower motor neuron um because of positive hypotonia and bilateral lower extremities and a reflection at the brachioradialis, biceps patellar, and Achilles reflex with hyporeflexia at the triceps. We ruled out CNS or the upper motor neuron because there is negative Babinski, intact sensory function, MSE, MSE, cerebellar and meningeal exams.
And then since we have chosen PNS, we wanted to determine if it is muscles, neuromuscular junction, or nerves. So we ruled in skeletal muscles predominantly affecting the proximal muscles. This is supported with the following information. So during the history, the patient developed progressive weakness described as easy fatigability, difficulty ambulating, standing from a sitting position, climbing stairs, and fatigability after walking a few steps. So these activities mainly uses the hips and thighs, which are both proximal muscles. And then the slurring of speech, difficulty swallowing, and the difficulty straightening the neck after flexion suggest involvement of the bulbar and neck muscles, which are both skeletal muscles. So during the motor exam, there is bilateral and symmetrical weakness in the proximal muscles, specifically during hip flexion and extension, which is 2 over 5, and knee flexion and extension, 3 over 5, with a relatively preserved distal muscle strength as manifested with 4 to 4 plus over 5. This suggests that the patient's muscle weakness primarily affects the proximal muscles rather than the distal ones. And then during the sensory exam, all sensory modalities are intact, presenting with 100% response upon light touch, pinprick, temperature, vibration, and proprioception. The absence of sensory deficits suggests that the sensory pathways of the peripheral nerves, spinal cord, and brain are preserved. Motor weakness in the absence of sensory deficits favors a myopathic process, suggesting localization at the skeletal muscle level.
And we also then we ruled out neuromuscular junction because of the presence of progressive muscle weakness without improvement after rest. And then also peripheral nerve because the pattern of peripheral nerve involvement should be distal first with sensory loss due to involvement of the long nerve. So yun yung tinatawag na stocking glove sensory. Also, I forgot to mention a while ago the possible involvement of the LMN could be uh the affected components would be lower motor neuron and the reflex arc. So that's it now. Next slide.
For our primary impression, based on the initial findings of our patient, our primary impression would be polymyositis. So polymyositis is an autoimmune chronic inflammatory myopathy characterized primarily by symmetrical proximal muscle weakness due to inflammation involving the endomysial layer of the skeletal muscles. The disease develops as a result of an autoimmune-mediated attack against muscle fiber, wherein there is an abnormal activation of cytotoxic T lymphocytes and macrophages directed against muscle fiber antigens. So for the first ruling in factor, the patient presents with symmetrical bilateral progressive muscle weakness as evidenced by difficulty standing and climbing the stairs, difficulty standing up from a seating position, easy fatigability during walking, and the motor exam revealed a hip flexion and extension, muscle strength score of 2 over 5, and knee flexion and knee extension score of 3 over 5. Since the inflammatory process affects the muscle symmetrically, the weakness is bilateral and proximal as seen in this patient. Another ruling and factor is the absence of upper motor neuron signs, since polymyositis is a disorder of the skeletal muscle fibers and not of the central nervous system. Another ruling and factor would be the preserved sensory function as evidenced by intact light touch, pinprick, temperature, and vibration and position sense. Since polymyositis affects muscle fibers only and does not involve the sensory nerve or sensory pathways. And another grading in factor is the presence of hanging head syndrome, as evidenced by the patient having difficulty straightening the neck after flexion. This may be an indication of inflammatory damage to the neck extensor muscles, which is also considered a proximal muscle, leading to inability to maintain head posture, resulting in hanging head syndrome.
So another one is dysphagia, where the patient presents with difficulty of swallowing, which suggests possible involvement of the pharyngeal and esophageal muscles. This is a recognized feature of polymyositis when the striated muscles of the oropharynx and upper esophagus are affected, leading to oropharyngeal dysphagia. Another is dysarthria. The patient also has slurring of speech, which is consistent with dysarthria. So weakness of the oropharyngeal and bulbar skeletal muscles involved in speech articulation can result in dysarthria. A recognized manifestation of inflammatory myopathies when the bulbar musculature is affected. So next slide, please. For our rule out, classification is the absence of deep tendon reflexes. In polymyositis, the patient presents with observed unless muscle atrophy significant. So next is rapid progression of weakness. So polymyositis typically persists months progressed rapidly to significant functional limitation within approximately 2 weeks, faster than usual progression of polymyositis.
So for our differential diagnosis, we considered Guillain-Barré syndrome or GBS. Based on the history, the patient had pneumonia 1 month prior to admission. GBS commonly occurs 1 to 3 weeks after a respiratory or gastrointestinal infection. And the patient developed progressive bilateral weakness in the span of 2 weeks. This timeline is consistent with the typical evolution of GBS. And GBS also causes bilateral symmetrical weakness. In this case, the patient had bilateral lower extremity weakness, causing difficulty standing and ambulating. The patient developed dysarthria and dysphagia, findings that may be found in more severe cases of GBS. Reduced and then absent tendon reflexes are also found in GBS. And in this case, the patient presented with absent reflexes. However, we have to remember that areflexia is not specific to GBS. And lastly, GBS affects children and adults of all ages and both sexes, with the highest attack rate in ages 50 to 74 years old. For the rule out features, the earliest symptoms of GBS are paresthesia and numbness in the toes and fingers. The patient did not report any paresthesia, numbness, or sensory complaints. The physical exam revealed intact sensation, while in GBS, sensory impairments such as vibration or joint position senses are reduced. The weakness also in this patient is most severe in the proximal lower extremities, involving the hip flexors and extensors, while in GBS, the classic presentation is ascending paralysis that starts in the distal legs. The patient also did not report any muscle pain or joint pain initially, while in GBS, more than half of the patients complain of aching pain in the hips, thighs, or back early in the illness. History and physical exam also did not show any autonomic dysfunction, which are common in GBS, such as tachycardia, fluctuating blood pressure, diaphoresis, and urinary retention.
Another differential diagnosis that should be considered is dermatomyositis. It is another type of autoimmune inflammatory myopathy like polymyositis that exhibits same or similar characteristics. It presents with symmetrical bilateral progressive proximal muscle weakness seen on the patient as bilateral lower extremity weakness. And on the patient's history, it was noted that the patient has difficulty climbing the stairs and difficulty getting up from sitting position. It also presents as muscle weakness with no sensory deficit since it only affects the muscle fibers. Evident in the patient's P and neuro exam, he has hip flexion and extension of 2/5 muscle grading, knee flexion and extension of 3/5 muscle grading with normal sensory exam results. Dysphagia and dysarthria can be present in dermatomyositis due to the affectation of the pharyngeal muscles, especially the oropharyngeal muscles and the esophageal muscles, which results in impairment in swallowing and slurring of speech. To rule out dermatomyositis, uh, there is the absence of characteristic skin changes, which is pathognomonic of dermatomyositis, namely the heliotrope thrush and the Gottern papules. The heliotrope thrush is seen as erythematous rash on the upper eyelids, and the Gottern papules are seen as erythematous papules with or without scaling found on the dorsal metacarpophalangeal and interphalangeal joints. And other supportive skin findings include the shoal sign, V sign, and the Gottron sign. The shoal sign is an erythematous uh, presentation of the posterior neck up to the upper back and shoulders. The V sign is erythematous presentation of the skin in the anterior neck and upper chest, and the Gottron sign is an erythematous patch or macule on the elbows or knees. And lastly, is the absence of deep tendon reflexes, as mentioned earlier in polymyositis as well.
Another differential diagnosis for this case is the statin-induced myopathy. Rule-in for this is the history of statin use of the patient. So the patient is on atorvastatin 80 milligrams once daily, a high-intensity statin for his coronary artery disease. Statins are a common cause of toxic myopathy. Another is proximal muscle weakness. The patient's chief complaint is bilateral lower extremity weakness with difficulty standing from a sitting position and climbing stairs, which fits this pattern. Also, the timing of onset. While statin myopathy can occur at any time, it often presents after months or years of therapy. The patient has been on atorvastatin since at least September 2020, and his symptoms began around that time period also. Another is lack of sensory involvement. The patient has no complaints of numbness, tingling, or sensory loss, and the sensory exam is completely intact. This is consistent with a primary muscle disorder rather than a neuropathic process. Now, the rule out for this patient includes absence of myalgia. The most common presenting symptom of statin-induced myopathy is muscle pain, aching, or cramps. The patient's history of present illness explicitly states that there's no muscular pain and in the review of systems, which makes a simple statin myopathy less likely. Another is the presence of bulbar symptoms. The presence of dysphagia and dysarthria suggests involvement of bulbar muscles, which is uncommon in uncomplicated statin myopathy. Last is the rapid progression of the symptoms of the patient. So the patient's weakness progressed significantly over 2 weeks, rendering him mostly bedbound. While possible, this degree of rapid progressive weakness is more characteristic of inflammatory myopathies rather than a typical statin myopathy, which usually has a more indolent or subacute course.
So now we proceed with the diagnostic plan. First, we do a complete blood count, which is an important initial laboratory test in patient with suspected polymyositis because it helps evaluate systemic inflammation and rule out other conditions. It also assess baseline organ functions and monitor for risk for complications. So important parameters include first, the RBC parameters. It is to assess for anemia. Patients with suspected polymyositis may develop anemia of chronic disease due to systemic inflammation. Hence, identifying anemia helps support the presence of chronic inflammatory process and may explain symptoms such as fatigue and reduced exercise tolerance. In the patient, the hemoglobin, hematocrit, and other RBC indices are within normal limits, indicating that there's no anemia present. Next is WBC and differential count. It is used to detect infection, inflammation, or other hematologic abnormalities that may mimic or coexist with inflammatory myopathies. So WBC count in suspected polymyositis may be normal or mildly elevated. The presence of leukocytosis may indicate an underlying infection, which can cause myalgia, weakness, and elevated muscle enzymes mimicking inflammatory myopathy. In the patient, CBC demonstrates marked leukocytosis with neutrophilia. Next slide, please. Next is platelet count. Again, indication is to evaluate inflammatory status and detect hematologic abnormalities. In chronic inflammatory conditions like polymyositis, reactive thrombocytosis may occur as part of the inflammatory response mediated by cytokines such as interleukin-6. In the patient, the platelet count is within normal range. Next slide, please. Now we go to the blood chemistry. First important parameter is the creatine kinase or the CK. It is the most important laboratory marker in suspected polymyositis as it is released when skeletal muscle fibers are damaged. It also helps support the diagnosis of inflammatory myopathy and it helps assess disease activity and severity. In the patient, the CK level is markedly elevated more than 50 times the normal value. Next is the CPK-MM or the CKMM, which is a muscle-specific isoenzyme of creatine kinase. It confirms that the elevated CK originates from skeletal muscle rather than cardiac muscle. It also supports skeletal muscle injury consistent with polymyositis or other inflammatory myopathy. Next slide, please. Next is AST-SGOT. In suspected polymyositis, AST may be elevated due to muscle cell destruction. And when AST elevation occurs together with markedly elevated CK, it supports muscle injury as the source. In the patient, AST level is elevated far above the normal range. Also, another parameter is ALT-SGPT. Elevated ALT in the setting of very high CK may indicate muscle inflammation rather than primary hepatic disease. And in the patient, ALT is also significantly elevated. And lastly, creatinine to evaluate kidney function. Since severe muscle breakdown may cause myoglobin release, which can lead to acute kidney injury. And also elevated creatinine may suggest renal involvement secondary to muscle damage or systemic illness. In the patient, creatinine is also markedly elevated. Next slide, please.
So additional tests include urinalysis, which is indicated to evaluate possible myoglobinuria due to elevated muscle enzymes and suspected myopathy or rhabdomyolysis. It is also done to assess renal involvement and check for metabolic complications of uncontrolled diabetes. So for the patient, there is the urinalysis shows dark yellow urine, turbid urine, indicating concentrated urine with possible cells or proteins present. There is also severe glycosuria, proteinuria, and hematuria. There is also moderate bacteria with trace leukocytes, which may indicate possible urinary tract contamination or infection. So for the clinical significance, the patient's glycosuria indicates poorly controlled type 2 DM. Blood with few RBCs suggests possible myoglobinuria from muscle breakdown consistent with inflammatory or statin-induced myopathy. The patient's proteinuria with rising serum creatinine indicates renal impairment and possible rhabdomyolysis leading to acute kidney injury. For the other labs, the blood CS, which is indicated due to the suspected sepsis after the patient developed hypotension and pneumonia during hospitalization, which will be discussed on the following slides. The sputum CS is indicated to identify the causative organism of pneumonia. So for the patient's result, there is no growth after 5 days. As for the sputum CS, there is growth of Klebsiella pneumoniae. This means that the finding confirms bacterial pneumonia caused by Klebsiella, supporting the diagnosis of septic shock secondary to hospital-acquired pneumonia. Next slide, please. For the patient's initial chest X-ray, this is indicated to evaluate chest pain and suspected pneumonia during prior admission. So the patient's result is clear lung fields, and the cardiac size cannot be assessed due to imaging limitation. So for the clinical significance, during this time, there is no radiographic evidence of pneumonia. Next slide, please.
So for the sensory nerve conduction, it is part of the NCV test that specifically evaluates the function of sensory peripheral nerves by measuring the speed and strength of the electrical impulses traveling through the sensory fibers. So for this patient, the peak latency showed prolonged in the median and ulnar nerves bilaterally, while the sural nerves latency are within normal limits, suggesting delayed sensory conduction in the upper extremities consistent with demyelination. For the conduction velocity, it shows reduced in the median, ulnar, and sural nerves bilaterally, more pronounced on the right and in the lower extremities, indicating diffuse slowing consistent with demyelinating neuropathy. Lastly, for the amplitudes, snap amplitudes are largely preserved with mild reduction in the right ulnar nerve, suggesting relative preservation of axons. So overall, the findings demonstrate diffuse sensory conduction slowing with relatively preserved amplitudes consistent with the predominantly demyelinating sensory polyneuropathy with minimal axonal involvement affecting both upper and lower extremities. Next slide, please.
So now I will be discussing the motor nerve conduction study. So based on the results shown in the table, in the median nerves, both sides show prolonged distal latency and slowed conduction velocity, suggesting demyelinating involvement of the motor nerves. In the ulnar nerves, there is mild slowing of conduction velocity with slightly reduced amplitudes, which suggests a mixed axonal and demyelinating neuropathy. Next slide. The peroneal nerves, particularly on the right side, show markedly reduced CMAP amplitude, indicating significant axonal degeneration affecting distal motor nerves. And then similarly, the tibial nerves demonstrate prolonged distal latency and markedly slowed conduction velocity, which further supports peripheral motor nerve involvement in the lower extremities. Next slide. So next, we evaluate the F-wave studies. So looking at the results, the median and the ulnar nerves show F-wave latencies within normal limits, while the tibial nerves show prolonged latency, suggesting proximal conduction velocity. Next slide. And then finally, we evaluate the H reflex study. So in this patient, the H reflex was absent bilaterally in the tibial nerves, which could suggest dysfunction in the S1 reflex arc, which may occur in peripheral neuropathy, radiculopathy, or proximal nerve dysfunction. Next slide.
So in summary, the abnormal findings of EMG NCV study shows diffuse slowing of conduction velocities with prolonged latencies in multiple nerves of the upper and lower extremities, consistent with the distal symmetric polyneuropathy. Sensory amplitudes are relatively preserved, while motor studies showed reduced CMAP amplitudes and slowed conduction velocities, indicating a mixed demyelinating and axonal neuropathic process. The pattern suggests a chronic neuropathy rather than an acute demyelinating process such as the Guillain-Barré syndrome, and most consistent with a metabolic neuropathy like diabetic neuropathy, given in the patient's history of long-standing diabetic mellitus. Next slide. So the needle EMG shows short polyphasic motor unit potentials with early recruitment in the proximal muscles, consistent with the primary myopathic process involving the proximal muscles and trunk. Minimal denervation suggests early evolving myopathy rather than a purely neurogenic cause of weakness. This is supported by markedly elevated CK levels and elevated liver enzymes indicating active muscle injury consistent with inflammatory or toxic myopathy. Next slide, please.
So for the 12 lead ECG, it stated that there's a complete right bundle branch block with persistent ST elevation of the anterior wall, possibly aneurysmal. So for it says that there's a right bundle branch block, meaning the right side of the heart contracts later than the left side. So basically, in normal setting, should be both ventricles should receive the signal at the same time so they can contract together. And then it says that there's a persistent ST elevation of the anterior wall, possibly aneurysmal. Um, Normally, yeah, the ST segment should be flat, but here, this usually means that there's already a damage to heart muscle. Um, and then in the arterial blood gas, um, it says that the pH is 7.34, so slightly decreased, indicates mild acidemia. And then PCO2 decreased as well, meaning suggests that the lungs are blowing off carbon dioxide, uh, possibly to compensate for metabolic acidosis. And then the HCO3, the bicarbonate, is decreased as well. Usually a low mark uh, bicarbonate indicates metabolic acidosis. And then the BCEF or your base excess is -14. Then usually the normal values are between negative to positive 2, meaning base excess of negative 14 could indicate severe metabolic acid deficit. Then for O2 SAT, 99, which is normal. And then it also says that the total CO2 is 11.7, which mainly reflects the bicarbonate concentration. Then the RR of the patient is 33, meaning tachypneic. Usually, the patient could be hyperventilating to compensate for metabolic acidosis. Then temperature is 36.3, normal range. Then A gradient, normally this value should be between slightly positive. Usually, if negative, the values are negative, there could be measurement variation, or since the patient could be in oxygen administration. The next slide, please. So for chest X-ray, um, there's a hazy opacities in the left retrocardiac region, meaning this could suggest that it was said that not present in the it could be not present in the previous X-ray and is newly detected. So meaning it could suggest lung infiltration. Then there's also a associated obscuration of the medial half of the left hemidiaphragm. So normally the left diaphragm border is clearly visible on X-ray. So if there's an obscuration, it could mean that no longer seen. And then this finding supports could be a left lower lobe pneumonia. So denoting pneumonia with partial atelectatic changes in the left basal segment means infection in the lung parenchyma. Then there's a pleural density seen in peripheral portion of the lower hemithorax, representing minimal left-sided pleural effusion. Um, this could mean the pleural density indicates fluid accumulation in the pleural space, and then peripheral portion of the lower hemithorax means fluid is located at the base and outer side of the lung. Then the rest of lung field are clear. The true cardiac size cannot be ascertained, and um, aorta is tortuous, means that aorta appears elongated and curved rather than straight. Hypertrophic spurs are seen along the lateral margin of thoracic vertebral bodies. And then the other chest structures are not remarkable. Next slide.
So for the muscle ultrasound, the sonogram of the bilateral lower extremity show a diffuse cobblestone appearance. So the cobblestone appearance, it is a patchy rounded fluid separated appearance of fat layers due to the accumulation of fluid between fat lobules, which is common in edematous state. So it is actually non-diagnostic, and it is just a general appearance of uh, an edematous state. Next slide, please. Next slide, please. The bilateral vastus lateralis muscles are heterogeneously hypoechoic with associated loss of normal fibrillar pattern. So the fibrillar pattern is unorganized, parallel linear striations of muscle fibers. However, in this patient, there is a heterogeneous hypoechoic appearance with associated loss of this normal fibrillar pattern, which is uh, correlated to the loss of muscle integrity, which manifests as the lower extremity weakness of the patient. We should also note that the bilateral vastus lateralis is part of the quadriceps muscles, which are responsible for knee extension and maintaining posture during standing and walking. In addition to this, the right flexor digitorum longus and brevis muscles are edematous from its proximal portion up to the mid portion. So there is likewise edema of the entire left flexor digitorum longus and brevis muscles. Next slide. There is also minimal fluid collection seen in the right suprapatellar space, which may be suggestive of joint effusion. And the bilateral biceps femoris, quadriceps femoris, and gastrocnemius muscle show normal fibrillar pattern. So in general, the posterior group of muscles are normal. The impression for this ultrasound is diffuse subcutaneous edema of the bilateral lower extremities with evidence of myositis in the bilateral vastus lateralis muscles and flexor digitorum longus and brevis muscles with right suprapatellar effusion. Next slide, please. So for the 2D echo, there are two results, one done outside and one done in the institution. So for comparison, assuming that the left side is the baseline, since the patient had a previous episode of a previous PCI intervention, the new results now show that there is no significant, there is an improvement of cardiac function. And when the repeat 12 ECG was done and to the echo, there was no significant change of cardiac function. So in general, the patient has no uh, underlying cardiac abnormalities. Next slide, please.
So as for the course in the ward, on the day of admission, the patient presented to the emergency department and of course underwent a baseline laboratory workup. So the initial findings revealing hyperglycemia and elevated muscle enzymes prompted the initiation of IV hydration, and therefore the previous maintenance medication of atorvastatin was placed on hold and the patient was subsequently admitted for further management. So for the specialty involvements, he was referred to neurology and scheduled for electromyography and nerve conduction velocity study to evaluate the neuromuscular function, and cardiology for the comprehensive cardiovascular evaluation and management. So for the first hospital day, the symptoms present include the progressive bilateral lower extremity weakness and associated with oropharyngeal dysfunction as evidenced by the dysphagia and pooling of secretions. And inpatient interventions include the nasogastric tube inserted with patient consent to ensure that safe enteral feeding and medication administration. So anticoagulation therapy was also initiated for the deep vein thrombosis prophylaxis due to the reduced mobility, and the IV hydration maintained. So the diagnostics done during this day include the EMG and CV, which revealed chronic diffuse distal mixed type of polyneuropathy in both upper and lower extremities. And this is consistent with chronic diseases such as diabetes mellitus neuropathy. So the EMG also revealed diffuse myopathic process involving the proximal muscles and trunk. And again, repeat creatinine, total creatinine kinase, and creatinine kinase isoenzyme were requested. So next slide, please. So for the second hospital day, the symptoms present include dysphagia with pooling of secretions, and muscle strength were still weak, more noticeable in lower extremities, and the mental status examination intact. So for the inpatient interventions, he was started on insulin glargine with IV hydration continued, while the diagnostics include the capillary blood glucose being monitored. Next slide, please. Next slide. So for the third hospital day, the symptoms present, the patient presented with slurring of speech, dysphagia, and pooling of saliva. Motor strength were stable with no progression and no associated headache, blurring of vision, or diplopia with complaints of constipation. So the patient was given lactulose and dulcolax, and diet was progressed to gelatin feeding on top of the NGT feeding and tolerated without aspiration, and he was referred to rehabilitation for physical therapy. So for the fourth hospital day, the symptoms present with improvement of symptoms, but slurring of speech is still present, and the motor strength
stable. So for diagnostics, repeat liver function tests, total CK and CKMM showed further increase. And again, the thyroid function tests were normal. So the urinalysis was requested during this day for evaluation of myoglobinuria. Next slide, please. So for the seventh hospital day, the symptoms present include the improvement of swallowing and the upper motor strength with no lower motor strength improvement. Patient was conversant with no dizziness and blurring of vision, and the diagnostics done revealed further increase in muscle enzymes, liver function tests, and creatinine noted on the repeat laboratory workup. So hepatitis panel were requested and showed normal results. So for the specialty involvement, he was referred to nephrology service for further management. And on the eighth hospital day, the working impression given was inflammatory myopathy and the inpatient interventions done. He was started on prednisone 10 milligrams per tab, 3 tablets in the morning and 2 tablets in the afternoon. And the monitoring is continuous. Next slide, please. So for the 10th hospital day, the symptoms present include the sudden onset of difficulty of breathing with tachypnea and respiratory rate is 33 cycles per minute, no desaturations or chest pain noted, and the inpatient interventions done was where the patient was hooked to oxygen which provided mild relief and IV hydration continued and increased due to the results of the ABG and chest x-ray which revealed respiratory alkalosis and again initially with minimal pleural effusion on the left lung.
So on the 12th hospital day, the patient developed hypotension with blood pressure of 80/50, which raises concerns for sepsis. There was no weakness, but the patient was awake and responsive, no chest pain or worsening respiratory distress. With that, a fluid challenge was administered, but hypotension persisted, so prompting the administration of dobutamine to improve cardiac output and norepinephrine for the persistent hypotension. So also, he was started on piperacillin tazobactam after the chest radiography demonstrated left lung pneumonia, which is consistent with hospital-acquired pneumonia. His insulin therapy was also adjusted due to hyperglycemia. Next, please. So here we could see that there was improvement in his strength of the upper extremities, while the lower extremities were actually still weak. Next, please. So on the 13th hospital day, the patient continued to experience generalized weakness but remained stable. He had occasional bilateral lower leg pain due to prolonged supine position, no dyspnea or chest pain. He was still maintained on vasopressor therapy to maintain his normal tension, continuing dobutamine and norepinephrine infusion. He was also on supportive care. He underwent repeat 12 lead ECG, 2D echocardiography, which showed no significant change in cardiac function. Next, please. On the 16th hospital day, the patient was more awake and conservant, improved in slurred speech, and persistent episodes of hypotension was also seen. So the patient appeared to have hypoalbuminemia, so he received albumin infusion followed by furosemide to restore intravascular oncotic pressure and promote diuresis, especially that there might be fluid shifts and in the case of his underlying heart failure as well. So mostly the lowered albumin levels could be multifactorial, especially that the patient is in a status of a systemic inflammatory state. Next, please. So in the 18th hospital day, the patient still showed persistent lower extremity weakness, and there was no new neurologic symptoms. So for the muscle ultrasound, it demonstrated diffuse subcutaneous edema of both lower extremities myositis involving the vastus lateralis muscles, edema of the flexor digitorum muscles, and right suprapatellar effusion, which confirms the active inflammatory muscle disease. And then on the 19th hospital day, the patient had severe bilateral lower extremity pain, described as pins and needles of 10 by 10 on pain scale. And this could be more related to the ongoing muscle inflammation and the neuropathic irritation. And thus, tramadol was administered for the pain control. And next, please. Yes, and the repeat laboratory test showed a significant decrease in CK and liver enzymes, indicating response to the steroid therapy. However, the serum creatinine remained elevated. This is why the IV hydration was continued. Because the patient was improving, the prednisone was gradually tapered to reduce the complications of steroid as well as have better control on the hyperglycemia. So now the patient is taking 10 milligram tablets, 2 tablets in the morning and 1 tablet in the night. And as I said, the IV hydration continued. For the muscle strength physical examination, we can now see that there is a drastic improvement in the lower extremities compared to the previous physical examination. Next, please.
Although the patient initially presented with features that could suggest GBS, the overall clinical, laboratory, and electrodiagnostic findings point away from a neuropathy and instead toward a primary muscle disorder. To summarize our diagnostic reasoning, we organized the patient's findings into this comparative table. The table contrasts statin-induced myopathy, polymyositis, GBS, and dermatomyositis. The yellow boxes represent findings that support the diagnosis. The red boxes represent findings against the diagnosis, and the pink boxes represent findings that may occur but are not specific. First, we ruled out a neuropathy such as GBS. Clinically, the patient's profound symmetric proximal muscle weakness contrasts with the ascending distal to proximal paralysis typical of GBS. In addition, the patient had a normal sensory examination, which strongly favors a myopathic process since GBS often presents with mild sensory loss. Although the patient demonstrated areflexia, which may be considered a classic feature of GBS, this can also occur in severe myopathies once muscle weakness becomes profound. Laboratory findings also argue against GBS. While GBS usually presents with normal creatine kinase levels, our patient had marked CK elevation peaking at 6,382, indicating severe skeletal muscle injury. Electrodiagnostic studies further supported this conclusion. EMG revealed a diffuse myopathic process rather than a demyelinating neuropathy, and ultrasound confirmed active myositis, effectively ruling out GBS. Next slide, please. So based on the patient's clinical presentation, laboratory findings, electrophysiologic studies, and medication history, we arrived at the following final diagnosis. The patient developed an inflammatory myopathy that is most likely statin-induced, which subsequently led to rhabdomyolysis and acute kidney injury. This occurred in the setting of high-dose atorvastatin therapy, which the patient was receiving for coronary artery disease. Therefore, our final diagnosis for patient EA is inflammatory myopathy, likely statin-induced, with rhabdomyolysis and acute kidney injury in a patient with coronary artery disease on high-dose atorvastatin. Next slide, please.
So here we differentiated our final diagnosis from other idiopathic inflammatory myopathies, particularly dermatomyositis and polymyositis. So dermatomyositis was excluded due to the absence of hallmark dermatologic findings, such as which was previously mentioned, the heliotrope rash and Gottron papules. Then polymyositis was also considered unlikely or maybe less likely because it typically presents with a more insidious onset over several months and usually demonstrates lower creatine kinase elevations. So in contrast, our patient experienced a rapid functional decline over only 13 days, with creatine kinase levels exceeding 6,000 IU per liter along with myoglobinuria, findings that are highly characteristic of severe statin-induced muscle necrosis, particularly statin-associated immune-mediated necrotizing myopathy. So additionally, the patient demonstrated progressive proximal muscle weakness manifested by difficulty climbing stairs, rising from a seated position, and weak neck flexion with bulbar symptoms such as dysphagia and dysarthria, which are typical features of proximal myopathy. Now, regarding our final diagnosis, we actually considered immune-mediated necrotizing myopathy brought about by statin use. However, although the laboratory and EMG findings support a necrotizing myopathy associated with statin use diagnosis, definitive diagnosis of IMNM requires detection of anti-HMG-CoA reductase antibodies or muscle biopsy demonstrating necrotizing myopathy with minimal inflammatory infiltrates. Next slide, please. So finally, the patient's hospital course and statin exposure provided further diagnostic confirmation. So standard statin toxicity typically improves simply by discontinuing the medication. However, in the case of the patient, muscle injury persisted even after the atorvastatin was stopped upon admission. In fact, the patient's CK levels continued to rise, which suggests a statin-triggered immune-mediated process rather than just a simple statin toxicity. It was also it was also only after initiating systemic immunosuppressive therapy with prednisone that the patient's CK levels began to decline and the clinical condition stabilized. The patient also developed rhabdomyolysis, evidenced by urinalysis findings of 3 plus blood with only a few red blood cells, including myoglobinuria from muscle breakdown. This subsequently led to acute kidney injury, demonstrated by rising serum creatinine levels due to myoglobin-induced renal tubular toxicity. So taken together, the patient's proximal muscle weakness, markedly elevated CK levels, again greater than 6,000, myopathic EMG findings, myoglobinuria, and exposure to high-dose atorvastatin strongly supports our final diagnosis. Next slide, please.
For the pharmacologic management of this patient, the most important initial step is the immediate cessation of statin therapy. For active inflammatory myositis, the mainstay of treatment is glucocorticoid therapy combined with a glucocorticoid sparing agent. Glucocorticoids are typically initiated using prednisone at a dose of 0.5 to 1 mg per kilogram per day with a maximum of 80 mg daily. In patients with severe or rapidly progressive disease, pulse therapy with IV methylprednisolone at 500 to 1000 mg daily for 3 days may be administered prior to starting oral steroids. And because prolonged steroid use can lead to significant adverse effects, steroid-sparing immunosuppressive agents are often introduced for long-term disease control. One commonly used medication is methotrexate, which is started at 10 to 15 mg orally once weekly and gradually titrated every 2 to 8 weeks to a target dose of approximately 25 mg per week. For patients with refractory or severe disease, additional immunomodulatory therapies may be considered. IVIG may be administered at 2 grams per kilogram per month, usually divided over several days. Another option is rituximab, a monoclonal antibody targeting B cells, which is given as 1000 mg intravenously in 2 doses spaced 2 weeks apart. Next slide, please. Although statin therapy must be discontinued in this patient, lipid-lowering therapy remains essential because the patient has underlying coronary artery disease and previous percutaneous coronary intervention, placing him at high cardiovascular risk. For this patient, alternative non-statin lipid-lowering therapies are recommended. One option is ezetimibe, which is given at 10 mg orally once daily. Another class of medications are PCSK9 inhibitors, which significantly lower cholesterol by enhancing hepatic clearance of LDL particles. Examples include evolocumab, which may be given at 140 mg every 2 weeks or for 20 mg once monthly, and alirocumab, which is typically started at 75 mg every 2 weeks. These medications are administered via subcutaneous injection, usually into the abdomen or upper arm. Next slide, please. In addition to treating the primary muscle disease, it is also important to appropriately manage the patient's existing comorbidities. Most maintenance medications should generally be continued unless contraindicated, especially those used for cardiovascular protection. However, certain medications may need to be temporarily withheld during acute illness. In this patient, the combination medication sitagliptin and metformin may need to be held temporarily because metformin carries a risk of lactic acidosis in the setting of acute kidney injury, particularly when the estimated GFR falls below 30 ml per minute. During hospitalization, insulin therapy is preferred for inpatient glycemic control because it allows better titration of blood glucose levels, especially in critically ill patients or those receiving corticosteroids. Additionally, if the patient is found to have vitamin D deficiency, vitamin D replacement therapy should be initiated. Next slide, please.
So the goals of non-pharmacologic treatment supports the goals of the pharmacologic treatment, which include the following. Next slide, please. After discontinuing the statins, the next step is to evaluate the predisposing and contributing factors that increase susceptibility to statin-associated muscle toxicity. So first is vitamin deficiency, particularly vitamin D, since low vitamin D levels have been associated with statin-related myopathy and muscle pain. Patients with reduced serum 25-hydroxyvitamin D may develop reversible muscle symptoms that improve after vitamin D supplementation. Therefore, vitamin D levels should be assessed and corrected as mentioned earlier. Second is thyroid dysfunction. Hypothyroidism is a recognized risk factor for statin-associated myopathy and can worsen muscle symptoms. Screening with thyroid function tests is recommended, and in this patient, thyroid function tests were within normal limits, making thyroid dysfunction an unlikely contributor. Third is renal impairment. This patient developed AKI secondary to rhabdomyolysis, evidenced by the elevated creatinine during hospitalization. Renal impairment can worsen statin toxicity by reducing drug clearance, hence management includes close monitoring of renal function, adequate hydration, and avoidance of nephrotoxic medications. Fourth is drug interactions. Some statins, like atorvastatin, simvastatin, and lovastatin, are metabolized through CYP3A4 pathway. Concomitant use with CYP3A4 inhibitors, including certain antifungals or macrolides, can increase statin levels and raise the risk for myopathy and rhabdomyolysis. Although this patient is not currently taking CYP3A4 inhibitors, this should be considered in future medication planning. Because the patient developed severe muscle injury with elevated CK levels, consistent with rhabdomyolysis, supportive management is essential to prevent complications related to acute kidney injury. Next slide, please. Next is non-pharmacologic supportive care, which primarily focuses on adequate hydration and electrolyte monitoring to prevent renal complications from rhabdomyolysis. First is fluid therapy. It is essential to promote renal clearance of the myoglobin. The recommended fluid administration is 200 to 400 ml per hour of isotonic crystalloid, which helps maintain renal perfusion and facilitates the clearance of myoglobin from the kidneys. Second, urine output and renal function should be closely monitored. The target urine output during treatment is at least 200 to 300 ml per hour, which helps reduce the risk of myoglobin-induced acute tubular injury. In addition, nephrotoxic agents should be avoided to prevent further kidney damage. Laboratory monitoring is also important. Creatine kinase levels, electrolytes, and renal function should be checked regularly. So next is physical rehabilitation, which is important because the patient presented with significant proximal muscle weakness and difficulty ambulating. The goals of rehabilitation are to restore muscle strength, improve mobility, and prevent complications of immobility. In the early rehabilitation phase, when the patient is weak or bedbound, management focuses on passive range of motion exercises, prevention of joint contractures, and frequent repositioning to maintain joint mobility and prevent pressure injuries. As muscle strength improves and CK levels begin to normalize, the patient progresses to the strength recovery phase. At this stage, isometric strengthening exercises such as planks, glute bridges, or static lunges may be introduced. These exercises allow early muscle strengthening with minimal mechanical stress, helping preserve muscle mass while preparing the patient for gradual resistance training, assisted standing, and balance exercises. Once sufficient muscle strength has returned, rehabilitation enters the functional recovery phase. The focus shifts to gait training, endurance exercises, and activities that restore independence in the daily mobility. Examples include sit to stand exercises, marching, hill to toe walking, obstacle navigation, among others. These exercises should be introduced gradually, as progressive physical training has been shown to improve mitochondrial function and increase skeletal muscle resistance to oxidative stress associated with statins. Another important aspect of recovery is nutritional optimization, which supports muscle regeneration following rhabdomyolysis. Therefore, dietitian consultation is recommended to ensure appropriate nutritional planning. First, adequate protein intake is important to support muscle repair and regeneration. The recommended intake is approximately 1.2 to 1.5 grams per kilogram per day, which for this patient corresponds to about 84 to 105 grams of protein daily. Second, the patient should maintain balanced caloric intake to prevent muscle catabolism during recovery. Third, because the patient has type 2 DM, a diabetes appropriate diet should be followed to maintain optimal glycemic control. Finally, adequate hydration should be maintained to support renal recovery and kidney function following the rhabdomyolysis. Finally, another important aspect of management is the prevention of complications of immobility. Because the patient experienced significant weakness and reduced mobility, preventive measures are necessary to avoid complications associated to prolonged bed rest. First, frequent repositioning should be performed to prevent pressure ulcers. Second, early mobilization should be encouraged when feasible, as this helps reduce deconditioning and improves overall recovery. Third, range of motion exercises to maintain joint flexibility and prevent contractures. And finally, patients should be monitored for risk of venous thromboembolism, which can occur due to prolonged mobility. Here are our references.
Thank you for the group for presenting a comprehensive discussion with regards to the case. Again, I'm Dr. Castillo. I'm your moderator for this session. Just a few comments. No, you can just imagine if you are really handling this patient face to face. You were given a case protocol. This is a typical scenario, especially if you're going through the course in the wards. As clinical clerks, within a few months, tama ba? Few months time, okay. Your task is to monitor such patients, especially these patients, can imagine, no, anything anything can happen. They become worse very abruptly. Now, just a comment in the case protocol, no? It was presented in such a way. If you will notice in the history of the present illness, chief complaint is bilateral weakness, tama? Bilateral lower extremity weakness. But the first statement is uh, acute coronary syndrome. So anything that you put in the history of the present illness is related to the present problem, right? So, my assumption is uh, since it's presented in such a way, the primary working impression should be inflammatory or statin induced. Because if you're thinking of poliomyelitis, um, that statement about the acute coronary syndrome, it can be on the past medical history. Okay, it's just a manner of presentation. One of the differentials is
Guillain-Barré syndrome. And we all know it's a nerve problem. Although Guillain-Barré syndrome has a purely motor variant, which is AMAN, okay? Purely motor, no sensory. But again, we are guided by our localization. No, that's why these patients, we encounter them, most of them, we encounter them as specialists. No? We encounter them um, having different diagnostic tests, as in different. No? So they are mostly misdiagnosed because at the onset, the problem is the neuro exam. Okay. Um, this patient, if you are localizing it to a muscular problem, then GPS is not part of your differentials because it's a muscle problem. No? So that's the very important thing. Important yun, muscle problem. If you're having duty in your emergency room, whether you're practicing as a general physician, company doctor, internal medicine, etc., etc. So one of the cause of the delay is doing this screening test, all of it, and then eventually patient will end up in seeing a specialist. No? So, um, what else? Dun sa one of the few last slides with regards to protein, well, just a comment. Problem din kasi with this patient, you have to discuss it with the nephrologist, because although it's an acute problem, if maybe it might develop into a chronic one. So again, limit naman yung protein when it comes to kidney injury. This is a complicated case, no? It needs a team, not just one doctor. Sharing my experience, no? I've seen statin-induced myopathy, but not this complicated. Usually, when you just stop the statins, patient will improve. One complicated case that I have involves not a statin, but well, patient having bipolar lithium toxicity. So become dehydrated. Um, Patient did not stop taking lithium and then eventually died. So ang problem naman with handling patients with psychiatric conditions is, again, if you're dealing with weakness, so that's the chief complaint of the patient, generalized body weakness. Difficult to assess, to be honest. So you need objective data, not just limited to your physical exam, but more on doing this creatinine enzymes and also. So this patient, again, as you can see, it can be multifactorial, no? Yung weakness. Kasi there's a DM polyneuropathy. So very important yung past medical history, review of systems. Is there any signs of DM neuropathy? Part of the differentials also in this patient can be diabetes mellitus-induced myopathy. But most common is DM polyneuropathy. Do you have any questions or comments with this case? If none, thank you. For the exam, expect very the questions will be limited based on the lecture. Again, if you're going to read all of it, the first part is the most important, yung approach. Kasi very important yung approach. The latter part of the book, no, the topic, more on certain type of diseases. This topic is a very subspecialized topic at our end, no. Usually, on my end, after giving all those medications, I usually refer them to a neurophysiologist who has a subspecialty in nerve and muscle diseases. Okay. Thank you.
Thank you, Doc.
Thank you
Thank
po,
you
Doc.
po.
Thank
Thank you
you.
po, Doc.
Doc.
Po, Doc.